Hi, good evening, everyone. My name is Sheena Wilson, and I'm going to be doing the webinar this evening. And of course, first, I want to apologize. Was completely unable to get on the, well, it wasn't even actually able to get on to the webinar itself, but uh, my computer decided to just continually go into a restart loop. How inconvenient can it be? But I am here now, and I want to go ahead and share my screen so we can go ahead and get started. I'm going to be mindful of everyone's time because I know that you all have uh, allowed for only a certain period of time in your busy schedule to do today's webinar, but I will still do an hour. So I will plan to stay on until 9:45, okay? For all of those who have to leave, I get it. No problems. But if you want to stay, and definitely if I can help you at all with your case list, I will do so. Okay, so again, my name is Gina Wilson. I'm one of the faculty members with Exam Pro, and we're going to be focused on case list review. Of course, if there's anything else that we need to kind of focus on to help you, I know most of you have already turned in your list, but may still have some questions about the construction of your case list. We can talk about that as well. Before I go on, I just kind of want to remind you of how you're supposed to participate in today's webinar. You are, I'm sure, already aware of the GoToWebinar control panel. It pops automatically up on your screen. And if you want it to not obstruct your view, you can open and close the panel with the orange button. If you want to view, select, or test your audio, this is the audio area right there. If you are opened up into the webinar through the computer, laptop, or what have you, any of your devices, it's going to usually default to the mic and speakers of your device. If there's an issue with connectivity, you can always use your telephone. Just remember to put in the audio pin so that if I take you off of the hot seat, then we'll be able to hear you. I don't really use this functionality of questions. It's just kind of hard to maneuver at the same time with the webinar and the case list. But if that's the only way that you can communicate, then I will peek at it every few minutes, probably every 5 to 10 minutes, okay? The best way to participate is to raise your hand. And that way I'll be able to identify that you want to actually participate. Okay, so I always start this off when I'm doing the webinars just to remind you why you're taking the oral boards. And this is not so that you can be tortured after years and years of training and practice. No, this is so that you become a board certified OBGYN. And ABOG has a very specific way that they like to test your ability. And the couple of those ways is first developing a diagnosis. So that's going to include identifying any necessary clinical issues that the patient may have, physical examination, laboratory studies, and any diagnostic procedures. And then after you've collected all the data that you need from the patient and everything that's going on with the patient, their symptoms, then the ABOG wants to know that you're able to select and apply the appropriate treatment for that patient, and that would be under elective or emergency conditions. So one of the things that you'll really need to focus on, something that we don't always do when we're in practice, is really kind of thinking of all of the options that the patient has, even if that option is not the most optimal for them. And I'll give you some examples, or as we talk through the case list, we can, I'll show you how that can benefit you when you're defending your case list. The next is to prevent, recognize, or manage complications. You may be one lucky person or several lucky people that did not have any complications for a whole year, and that is great. That being said, complications always show up in Dallas. and your examiner may actually look at your case list and say, hey, I don't see any complications. Let's come up with one. And we'll be doing that tonight as well. And then, of course, plan and direct follow-up care and continuing care, especially for patients who have chronic conditions that they'll have to come back to your office often. Maybe it's even just a patient who had a leak and they have positive margins, just how you would manage that patient in follow-up care. All right? Okay, so we're going to go ahead and do the case list review. And I'm going to pause my screen and go ahead and open up the opportunity for anybody to raise their hand if they want to participate. Now, I know that everybody has not turned in their case list, so if there's a case that you know about that's on your case list you want to talk about, I'm completely okay with that as well. And let me go ahead and, you're not going to be able to see the background, but let me pull out the case list. All right. Okay, so I don't see anyone raising their hand, and I'm checking the area to see if anybody has any questions. Obviously, if you have difficulty hearing me, of course, that would be good to share in the question box as well. Give me a quick second. Actually, Dr. Alexander, I'm going to unmute you while I'm still trying to open up the case list that we have. Do you have a question, though, that you wanted to ask, or you wanted to review one of your cases?
Yeah, I'm good to go over a case list, whatever you want to do. We've been
Okay.
OB in office, so maybe a GYN or even office, any of those is fine.
Any of those. Any of those. Excellent. So let me ask, and the technical difficulties have not stopped on my end, so that's why you probably hear me pausing a little bit. But did you happen to turn in your case list?
Yes, I did, to Beth Tenenbaum, yeah.
Excellent. So we'll go ahead and figure it out. Can you do me a favor and just tell me a little bit of what you're currently doing as far as a practice?
Sure, yeah. I'm a generalist, in Arizona, Phoenix, that does, OB, GYN, a little mix of everything.
Excellent. And do you have pretty much a third of your practice is office? Well, I would say most is office, most is OB, or it's about the same all around?
Yeah, I mean, I do office, like, I have kind of like an interesting thing where my call days are on my office days, and my cases and everything like that are on those days. So yeah, I would say like a third, a third, a third, with everything. So, office,
Gotcha.
hospital, and procedure stuffs. Yeah.
Okay. So I actually have the case list open, and I'm specifically looking for your last name. I don't see it, so I'm just going to look into another. Do you know when the last time when you turned it in?
Probably that same day that they sent out the email. I can look it up and see.
Oh, I think I see it. I see. It looks like they're putting it under people's first names.
Oh, okay.
So we'll just go ahead and start. The first thing that looks like it's listed, and let me double check to make sure this is your last name before I put it on the screen. I don't want to share the wrong person. It's going to be office, if that's okay.
Sure.
Oh, no, and that is not. That is a different Alexander. I don't see it. And I can actually share the screen and you can tell me if you're seeing something different, but yeah, and I thought that it was you, but this is somebody different. Do you Do you have your case list in front of you, or you have one that you know?
I mean, I have my case in front of me, sure. Yeah.
Okay. Do you want to just pick a random one and then give us like the 30-second overview, and then we can go from there?
Sure. Let's see. Um, mm, 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 mm.
It's always a, should I just tell you the number 12? Maybe just pick that one.
Yeah, sure. Sorry.
All right.
Yeah. So that's
That's
an
okay. It's always hard to pick
So
one.
yeah, so on office practice, so it's a 27-year-old G0P0 complaining of, let's see, chronic pelvic pain. With it, she's failed NSAIDs and oral contraceptive pills. She has a strong family history of endometriosis. Her ultrasound showed a 4 by 3 centimeter complex cystic ovarian mass. And we did some treatment option counseling, contraceptive counseling as well, and then we scheduled a diagnostic laparoscopy for her.
Okay. Is this a patient? This is your office case, right?
Yes.
Okay. All right. So you have this 27-year-old that comes in and she's complaining of chronic pelvic pain. Tell me, first of all, 27, G0, what would be your differential diagnosis for the patient? And that's usually kind of how the questions start. They just kind of want to see, what are you thinking off the top of your head when that person shows up in your office?
Mm-hmm. Sure. So with kind of doing the pelvic pain and pain in general, doing it by systems. So with just starting off with GU system,
Mm-hmm.
doing urinary complaints, urinary tract infection, GI. You can talk about constipation or ulcerative colitis or any kind of bowel disorder, musculoskeletal pain as well for like that system. You could do psychological, so depression, or even if the patient was coming in for abuse screening or something like that, and her complaint was pain. So like psychological like that, and then going into GYN, so just cramping with her periods, and so menorrhagia or dysmenorrhea, I guess, and then you could also certainly in this case endometriosis could be part of that differential.
Okay. All right, good. I like the fact that you set it up with systems. It is intriguing that you started off with systems not like GYN, but is that just a way for you to remember some of the other non-GYN causes?
Yes.
Okay. All right. So when you're thinking about all of that, um, uh, all of those causes that you mentioned or diagnosis, what was your approach in evaluating the patient? And because it's so many systems, I'm curious as to what your multidisciplinary approach was to
Sure.
evaluating her pain.
Sure. So with history and physical, what is positive, pertinent positives
Uh-huh.
like physical exam. So especially doing an abdominal exam, seeing before doing a pelvic where this pain is localized, and doing a pelvic examination bimanual, even recto-vaginal exam, just to kind of assess to see if there's any abnormalities in that posterior cul-de-sac. And while the patient's in the office, we usually do like a urine test, urine dip, just to make sure if there's any signs of an infection process, not on a urine culture that's reflexed and everything, if anything is positive on a UA. So that's kind of that first step in evaluating them on that exam.
Good. So you're right. With a person who has chronic pelvic pain, first of all, definitely getting a really good history. That way you can kind of sort out, all right, what system am I dealing with? Is this a straightforward GYN issue? Is this complex where it may be multiple systems that could potentially be involved? Is this something that I can rule out here in my office, or do I need to send her to a specialist? Those are really good things to consider. And of course, you would be doing the same on your physical exam as well. Now, that being said, for this particular patient, what was your main primary differential diagnosis, maybe the top three, and how did you evaluate her, especially because you mentioned a couple of things about her?
Yeah. So I think the biggest thing was that family history of endometriosis, the fact that she, with her history, that, this pain was really associated with her menses, worsened with that. She had was treated actually by a different gynecologist before establishing herself with my practice, failing like an NSAID trial and OCP. So that was kind of like the first step. And then, getting, that kind of tailored everything, to that differential, ruled out that musculoskeletal pain, especially since, it didn't improve with, ibuprofen or Motrin or whatever it was that we gave her, or whatever she was on. So, kind of tailoring, okay, well, if it's kind of sounds like, endometriosis, we should get a pelvic ultrasound. So, fortunately, we have that in our office. So we were able to get that, before she had left, and then kind of evaluated it, and it showed, this complex mass and everything, which was, had the characteristics just of an, possibly like an endometrioma. So, that kind of also then helped solidify, that this is probably the differential diagnosis that we have to go with. Her abdominal exam, the ultrasound of the cyst was small, or 4 by 3 centimeters is, still the size of an ovary, but, not something so large that we were concerned of, and especially on an abdominal exam, that she didn't have any acute findings of like torsion or anything, which, certainly could be a part, but she didn't have any of those kinds of symptoms. So.
Okay. So, quick question.
Yes.
What question did I actually ask you?
What did you ask me? I don't something about
exactly. Yeah. So and listen, I get it. It's early, but I always like to kind of have give you something to consider. So the question was more of what thinking. What was your primary differential for that person, and talking a little bit more about your assessment. And you kind of went more into, I guess, the whole thing. You went even down to how you treated the patient and went into the differential diagnosis. And you want to be, the diagnostic laparoscopy. You want to be careful to really focus on what they ask and stay there, because you may change the trajectory of the test, right?
Sure.
So I'm going to ask you a different question, and let's see if you can just really focus on the question itself and stay within that question.
Okay.
So you said that you counseled the patient on contraception, right?
Correct.
Options.
Correct.
Did I hear that correctly? Okay.
Yes.
So how do you counsel patients regarding family planning?
When I approach a patient with family planning, I determine first what they'd used prior and what options, and then go in the line of reversible contraception versus or long-acting reversible, and then just other different types of management, IUDs, patches, pills, and vaginal rings, and decide on based off of their history and physical, if there's any conditions that preclude them from having certain contraceptive management.
Okay. All right. So it sounds like you did stay within that, space of how you counseled the patient, which is good. And as you continue to practice, you'll learn to really kind of say, okay, let's focus on the HPI.
Mm-hmm.
When does this patient want to get pregnant? What has she used in the past? These are the things that I would have evaluated her on. And after the complete evaluation, because you don't want to talk too much about that piece, you talked about the least invasive of family planning, and you go all the way to the most invasive, which could be permanent sterilization. Even if that's the most optimal choice for the patient, when you're counseling the patients or talking about how you counsel the patient, it shows that you're giving them all of the options, and you're not saying, hey, you're 21, you only need to take some pills or something like
Sure.
that, right? But I do like the fact that you did talk about more options. Did you find that it was almost difficult to kind of stay within just that space, especially since the question wasn't really germane to your case?
Yes, yes. That I wanted to
Okay.
give enough information and not, go off on a tangent for 20 minutes about, contraception when we're talking about something else. So yeah, I think definitely, just as you said, kind of tailoring it. So the response.
Exactly. And I think the more you practice, you'll get used to it. But I think you're doing a really good job so far. Do you have any specific um, issues on any of your case lists, or we can take you off the hot seat and give you a little bit of a break if you'd like?
Whatever you'd like to do. Um, I don't think I have any, major questions, I think, on some of my lists. So yeah, if you'd like to give someone else the opportunity, I'm okay with that.
Okay. Well, great job. Thanks for participating. And I think that you're actually at a really good starting place.
No, thank you very much. Take care.
Absolutely. Okay. So I'm going to give anyone else, if you want to kind of get on the hot seat, we call it the hot seat. It's really not a hot seat, it's a warm seat. It's early in this process of studying. And we got Dr. Melissa. I just unmuted you. And you tell me when you are ready. Okay, it looks like green light.
Hi, how are you?
Hi, I am doing fantastic. Thank you for asking. And I found your last name.
Okay.
Dr. Alexander, I might shoot an email to Beth to make sure that we have your case list loaded. Okay, Dr. Melissa, what do you want to do over these next couple of minutes?
So I was wondering if we could do a problem case that I have. It's on OB.
Absolutely.
Awesome.
So let me pull it up. And what page is it on?
It's number 42.
It's case number 42?
Yes. I do not have 42 pages.
Yeah,
Thank
I
God.
was just thinking, Gina, she doesn't even have 42. All right, I see it. And let me zoom in just a little bit. Okay, so are you able to see it in the middle of your screen?
Yep.
Perfect. Okay, so I have no idea what's going on, but I see a lot of words and letters. So do you want to give everyone on the line quick and dirty with what happened to this patient, and we can kind of talk through it?
Sure. It is yeah.
Yeah. As soon as I said, I was like, oh, yeah, okay, now I see.
Uh-huh. Yeah, so I brought this up because I kind of feel like it would be, I mean, I know people go through your list really fast when they pick cases to go through, but there's with the neonatal death stand out.
Yeah.
And so I kind of just want to have an idea of, I know they go through cases very quickly, but I'm not quite sure what they would exactly ask. But anyway, it's a gravida 3 para 2 at 38 and 6 weeks who did have COVID, and upon our evaluation and triage was met criteria for the diagnosis of preeclampsia, And so an induction of labor was started on her during the midst of her induction. After water was broken in 5 centimeters dilation, she had a recurrent category 2 into a category 3 tracing with a quick standing in labor from 5 to 9 centimeters quite quickly, after which time a cord prolapse was appreciated. And I'm going really fast with this, but so with the cord prolapse, and of course a Swiss cheese model of not all of the right people in the right places, and a staff shortage and calling for an emergency C-section. An emergency C-section was done, and there was also difficulty with the neonatal resuscitation, and the baby passed away.
My.
Yes. I guess so. I have a few difficulties with my ability to explain it because there's a couple points from my standpoint as far as she progressed quickly, and also at the time of the cord prolapse, with the lack of helpful support staff around when I diagnosed the cord prolapse and said for the emergency C-section, I did not support the head and ride the bed. And this will, of course, haunt me forever.
Someone else did?
No.
Oh, okay.
Yes.
Yeah, I don't. So there was no pressure taken off of the cord.
Correct.
Oh, yeah. I don't know if I would mention that. Yeah,
So,
yeah. That's.
I want to be honest in how I present things. And part of the reason why I didn't go back right away, so I actually had also, I was physically sitting on the bed for during this whole process of when a category 2 tracing even started, because I broke her water myself, and her deceleration started within 2 minutes after that, and I came right back and said, hey, what's going on? So it's not that I appreciated the cord right then, but she did progress within 10 minutes from 5 to 9 centimeters, and there was palpation of a cord by her ear that I had her do a practice push, and I no longer appreciated it whatsoever. And this case has gone through M&M and peer review and etc. and so on, and also went through M&M on the pediatric hospitalist side because they were unable to appropriately bag and intubate the baby too.
Right.
So I just don't want to be so scattered, and I don't want to point fingers, but I'm not sure where they will take me.
Yeah. So first of all, I think that this is I recognize that this is a really tough case. I hate, of course, that you had to experience it, and of course, even more so the mom and the family. I think that one thing you should rest assured in is when we look at your case list, that's whether we're going to do a mock oral exam or your examiner's taking a look at it, they don't know the story. Right? So that automatically gives you, I don't want to say the upper hand, but it allows you to kind of relax and say, okay, they don't know exactly what happened. The second thing is hindsight is always 20/20. Everybody knows that.
Yes.
There's always things that you can do differently. And, so I don't want you to continually beat yourself up over something that has happened. If it has happened, I'm sure you've learned from it.
Oh yes, absolutely. Yeah.
So let me say this, though. When I glanced at the case, not knowing the story, um, I saw cord prolapse. Right off the bat, I know that there is, increased chance of neonatal, morbidity or mortality right off the bat. So that matched the apgars. And then there's this person who's preeclamptic, but there's an emergency C-section because I'm looking, okay, what are we doing about the preeclampsia? So I'm looking at that. And then at the same time, I'm looking at there's a person who had COVID-19 infection. So they could go in any direction. And just because in practice, we'll ask you, give us a brief, give us an idea of what happened, that's not always how your examiner is going to ask questions, right?
Mm-hmm. Right.
They could very well say, I see there's a 25-year-old G3P2, 38 weeks and 6 days, that had significant complications in the antepartum period, intrapartum, and it looks like postpartum period, leading to APGAR scores of 1 and 1. What are the components, or how do you define the APGAR scores, or how do you calculate it? That could be the first question that comes out of their mouth.
Right.
So then the question is, Dr. Melissa, how would you answer that question? How do you calculate APGAR scores?
So the APGAR score is calculated by fetal tone, respirations, heart rate, grimace, and color.
Okay.
That's based on a score from a 1 to 10 score. It is calculated usually at 1 minute of life, 5 minutes of life, and 10 minutes of life.
Okay, good. Now, I purposely just asked you that question just to kind of take you a little bit away from the case itself. So now we're going to get into the little bit of the nitty gritty. It looks like during the induction of labor process, this patient had a category 2 tracing. Talk to me a little bit about the intrauterine resuscitation that you provided.
So with this patient's intrauterine resuscitation, an IUPC and a fetal scalp electrode were placed to better assess her contractions, as well as the initial variable decelerations, which were noted on the tracing. Her Pitocin was stopped, an IV fluid bolus was run, the patient was repositioned multiple times. And also during this time, a quick progression of labor was noted from progression from 5 to 9 centimeters.
Okay. And that's a good way of kind of shifting and telling them exactly what happened with the particular patient. So it looks like this patient also had a cord prolapse. Tell me a little bit of, what are the risks of having a cord prolapse? What are the risks that a patient has, risk factors for a cord prolapse?
Risk factors could
in general.
Like malpresentation, so transverse or breech presentation, rupture of membranes when like fetal head is not well applied, polyhydramnios,
Yeah, and you've named some great ones.
Those would be the ones that I think of off the bat.
That's good. Breech presentation, CPD, multiparious, which she had, multiparious patient. Sometimes congenital abnormalities as well. So yeah, all of those things could contribute, and maybe for her, it could have been because she was multiparious. It doesn't sound like the head was as engaged as you probably wanted it to be when you did the amniotomy?
Correct.
Okay, yeah. So if I had to present the case, if someone said, hey, Sheena, you got 30 seconds or so, I'm going to give myself grace because it's been a minute since I've actually had to take the boards. But I'm going to give myself grace. I'm going to say 45 seconds. Don't time me. I would probably say this is a 25-year-old G3P2, 38 and 6 weeks, that we had to do an induction of labor because of confirmed preeclampsia. Was this with or without severe features?
So, it was without severe features.
Okay, so without severe features, but during the induction process, we did run into some difficulties with the category 2 progressing to category 3 tracing, especially related to the amniotomy. There were several intrauterine measures that were taking place, but they failed. Eventually I diagnosed the cord prolapse. We took the patient back for an emergency C-section, but were unable to resuscitate the neonate after the delivery. Period. You don't have to talk about who wasn't there. You don't have to talk about who wasn't on the gurney. You don't have to talk about where anesthesia or the CRNA was outside smoking a cigarette, right? I didn't lie. Correct? Or did I? Are you there, Melissa? Oh, I think I lost you. All right. So for those who are listening, there was no lie. It was just about talking about high level information about this particular patient, and just the facts. There was a failed induction because there was a fetal heart tracing and poor category 2, category 3 tracing that it resulted in an emergency C-section during a cord prolapse. Okay. And for all of those, I think we completely lost Melissa. For all of those who have cases like this, when you're presenting it, focus on the facts of what exactly happened. Try not to do an RCA, root cause analysis, especially while you're presenting the case, because there's some things that you will have to defend. And that's for this case, number 42, you have COVID-19 infection and pregnancy. And that can be a whole conversation of just COVID-19, how it affects pregnant patients versus patients that are not pregnant, vaccination counseling. Those are things that you could talk about. Just how preeclampsia with and without severe features is actually diagnosed. Preeclampsia with severe features, how it's managed during the intrapartum and even postpartum period. You can talk about, obviously, induction of labor, Bishop scores, what criteria you use when you're going to induce someone, what criteria do you use where you're going to augment the labor process. So there's so many things that you can talk about that applies to so many other the cases that you have to do. So this should be just a lesson for everyone. Make sure you're able to speak about your case on a high level, but at the same time, make sure that you're able to talk about all aspects of what's going on with that patient. Okay? All right. And I see Melissa, I'm sorry, I lost you as well. Hopefully you can go back and listen to the recording to hear the answer. Okay, so we're going to go ahead and unmute Dr. Jessica. And I am going to go ahead and take this case list down. And Dr. Jessica, whenever you're ready, you just let me know how you want to participate tonight.
Yes, please.
Oh, I hear you.
Oh, good.
All right, so how are you and how would you like to participate? I see your case list.
Yep, I would like to do whatever list you would like, I think.
Okay, all right. Hold on one second, I made it. Okay, I put my computer speakers on. All right, so we've done an office, we've done an OB, you have a GYN case list. What are you currently doing for your practice?
I'm in generalist practice. I'm reasonably private practice. I'm reasonably new to my practice. I've been there a little less than a year and a half now. So my practice is about 50-50 OB to GYN, maybe 60-40 OB to GYN while I build up my practice.
Okay. Do you have a case that you want us to review, or do you want
I think
just
I'd
to
rather
pick?
do dealer's choice so that I can be more surprised and figure out my answers better.
Wait, say that again. I didn't hear you.
I think I'd rather do dealer's choice so that I can figure out my answers a little bit better and feel more on the spot.
All right. So, GYN?
Sure.
Okay. And no case that you really want to, I'm just going to randomly pick whenever your case list decides to show up. There we go. And, ooh. Okay. All right. I'm going to give myself 2 more seconds, and I'm just going to randomly pick this. See, this is what I was telling Dr. Alexander. It's super hard when you got all these choices. You're going to start with this second page, I believe. We're going to start with number 2. All right?
Yes.
Okay, and I'm going to zoom it in just a little bit. Are you able to see your screen pretty well?
Yes, ma'am.
Okay, so we're just going to start off easy. You tell me just a little bit about this case number 2.
Sure. This patient presented to me complaining of very heavy menstrual periods with intermenstrual bleeding. So I was the first person to work this up for her. I got an ultrasound and then an endometrial biopsy for her. The endometrial biopsy was benign. The reason why and then I offered her some medical management in the form of progesterone, which she bled through for about 6 months before we decided to proceed with a hysterectomy. The plan was to do it laparoscopically because she has, a small uterus. The fibroids were very small. It was more like pebbles rather than boulders. So we went in there, we got started a little bit, and then we realized that we were not going to be able to safely dissect the bladder down, given how many C-sections that she had. So we made the decision to open her, and when we opened her, we did not get much better access to the cervix, so we opted to amputate at the cervix. Since that time, she's been doing much better. Of course, she's no longer bleeding because she no longer has a uterus, and she's very pleased.
Okay, good. So, it's interesting that you have this case because there's some language that I see that almost seems like it's contradicting. But I'm going to ask you a couple of questions first before I get to that. When a patient has abnormal uterine bleeding, what are some of the causes of abnormal uterine bleeding?
There's several of them. There are endometrial polyps. There's adenomyosis, leiomyomas, medications, among many others.
Okay. So it sounds like you started off with PALM COEIN, right?
Yep, and then the cone fell out of my head.
That's fine. All right. So let me ask you, what was the cause of this particular patient's abnormal uterine bleeding?
I believe hers was due to the fibroids and the adenomyosis.
Okay, good. The fibroids and the adenomyosis. So you said that the patient failed medical management and she basically didn't want any minimally invasive procedures as well. Let's say she didn't want a hysterectomy. and she still failed medical management. What were some of the other options that you would counsel her?
Sure. We talked about a variety of other options once we decided that the IUD was not for her, including a hysteroscopy to evaluate if there's a polyp or something in there with polypectomy and DNC, and endometrial ablation, and we briefly discussed uterine artery embolization.
And it sounds like she didn't want any of that.
Her philosophy was, I'm done using these parts, why do I need them?
So that's an interesting philosophy. So when you have a patient that says that, I'm done, with my uterus, what's the benefit of me keeping my uterus and trying something more minimally invasive? How would you counsel someone with that thought process?
Well, we went through that a major abdominal surgery has more morbidity associated with it than a more minor procedure does. A longer recovery time, a longer hospital stay, all of the greater cost of care. However, she was very certain that she didn't want her uterus and she wanted the most definitive management that we could give her. And the most definitive management that we could give her was hysterectomy.
Good. Now, thank you for saying that. What you did was you showed me as your fake examiner right now that you are able to counsel patients. Because sometimes people will say, I don't want that because I'm fearful. I just want to be done. I don't want anything that I would have to deal with maybe 5-10 years down the line. And it sounds like you did give her the risk associated with or even the pros and cons associated with something more minimally invasive versus, the permanent solution that she wanted, but increased risk, increased cost, increased recovery. So thank you for that. That was really good. Good answer. Now, when you're actually thinking about doing a hysterectomy on a patient, what criteria do you use to determine the route? What type of hysterectomy they're going to do? What criteria do you use?
Sure. Well, I don't have robotic privileges at my institution, so that's automatically out. And I'm not comfortable with regular vaginal hysterectomies because I wasn't well trained. Okay. So that leaves for me total laparoscopic, abdominal, and laparoscopic assisted vaginal hysterectomies. My big deciding factor is the size of the uterus. If the uterus is greater than about 12 centimeters, I usually would steer towards an abdominal route, unless the patient really wanted to avoid abdominal, and then I would counsel them that they have risk of laparotomy if we choose to proceed with a minimally invasive route. Generally, my preference is to do the LAVHs for pretty much all of the patients, and that's because it gives me access to both the abdomen and the vagina, and it gives me the ability to close from the vagina, which is my preferred route of closure and my most practiced route of closure.
Good. I like the fact that you identified, hey, there are other ways to do a hysterectomy, including vaginal hysterectomy, but I'm not necessarily, that's not where my comfort zone is. And because I don't have that comfort zone, I may be putting my patient at more risk. And I appreciate you saying that because you have this tiny little uterus that I'm looking at, this 86 grams. The thing that really kind of other criteria to take a vaginal hysterectomy out is the fact that the patient had prior cesarean section. So I'm assuming she didn't have any descensus and way too much scar tissue, a fixed kind of uterus. But I like the fact that you mentioned, hey, this is an option, but it's not an option that I would necessarily give to a patient for different reasons. So now let me tell you what caught my eye, Jessica, with that. This patient has abnormal uterine bleeding and I saw multiple fibroids. I missed the small and the tiniest little uterus.
Yes.
Only 86 grams. Yeah. So I think that caught my eye a little bit. when I was thinking, and of course, the fact that although she's over 40, she's 43. I'm going to ask you one more question, but it's not a question that you can actually see on your list because it doesn't exist. And you remember at the beginning I said ABOC wants to know, how do you prevent and or manage complications? Well, this one doesn't have any. But let's say on postoperative day number 2, the patient it has a fever of 101. That's what the call that you get from the floor. What would be your concern? How would you evaluate the patient and manage it?
Sure. I would go and see the patient and ask the patient how she was feeling and if she had any symptoms, with particular interest in her, if she's having any dysuria or anything like that. I would also make sure that she's ambulatory, even though DVTs don't usually present until a little bit later. I would make sure that she's walking around. I would take a look at her incision, again, a little bit earlier than we would expect a wound infection to present, but I would take a look at her incision and make sure that it looks as it should. I would order a urinalysis and urine culture for her because I'm towards this being related to the instrumentation of her bladder.
Okay.
I would order some Tylenol to try and break her fever as well. I would also order a little bit of Tylenol to try and break her fever as well.
Okay. All right. Good. So you kind of talked about what your differential diagnosis was, including something that probably would not be her issue, and then some of the ways that you would evaluate that. And believe it or not, there are your examiners may ask you multiple questions in just one question. And obviously they could potentially ask you about a complication, especially if you don't have one on the patient. So definitely a good start. So, all right, good job. How do you feel that you did?
I feel like I answered the question, some of them maybe incompletely.
Yeah.
I don't think I got enough of the answer to have it pass.
I think that the more you practice, the more you'll be able to organize your thoughts and provide a succinct but very complete answer to your examiner. It comes with time. I think where you're starting right now is really good. I said July. It's not July, it's August, but it's early. And the best thing to do is just continue to practice out loud. So I thought that, you definitely had a good start. Thank you for volunteering tonight.
Thank you.
Absolutely. So I promised that I would stay on a little longer. I understand that if you have to go, it's okay. I want to see if we can get one more person in the hot seat, and that's Dr. Chioma. I see that you have your hand up, and I do see your case list. Just ask you, how do you want to participate tonight?
I'd like to practice, I guess, presenting or getting asked a question on any random case, if you're okay with that.
I am okay with that, absolutely. So we've done GYN, we've done OB, and we've done office. So do you want it to be a random case on a random case list, or do you want to pick the case list and then I pick a random case within that case list?
Oh, yeah, I can help because that might be hard. We can do office and then just pick a random one from there. It'll be fine.
We'll do that. We will do that. And let's see. I feel like when I'm glancing at you all's list, I need to start singing the Jeopardy music, just so that you all don't have to listen to the quietness. But, ooh, you got some good cases on here.
And I have a lot of preparation to do.
It's okay. It's early. It's okay. The thing about it is, you do have preparation. Everybody has to prepare. But, you are going into this exam knowing way more than your examiner knows about your cases, right? So, just remember that. I'm having difficulty picking between a couple of these. I'm going to give myself one more second. All right, I'm going to go with the one that I said I was going to go with. Oh, now I can't find it. Okay, we're going to do number 10.
Okay, sure.
All right. Okay, can you see number 10?
Yes, I can.
Perfect. Okay, so I'm going to start off just like I started everybody else off. Just remember that this might not happen when you actually take your exam, but I just kind of want to get everyone in the habit of practicing out loud and just talking. So, number 10, tell us a little bit about the patient. Give us the quick and dirty 30-second review of what happened with this patient, starting with how she presented and what you did for the patient.
Sure. This is a 53-year-old G1P1 postmenopausal patient who presented for evaluation of bothersome vasomotor symptoms that she described mainly as hot flashes that she would experience throughout the day, but worsening at night. She had tried conservative measures such as, decreasing the ambient temperature in her apartment, and I believe had tried some dietary changes without improvement in her symptoms. So she presented to discuss additional options, primarily medical management.
Okay. So good. You kind of just gave us a little bit of an overview. So you said the patient was postmenopausal and having hot flashes.
Correct.
When a person comes in with complaints of hot flashes, I use my quotation fingers, what is your differential diagnosis for the patient?
So it would depend on age, but typically if they're in the perimenopausal age range, maybe mid 40s or later, typically I do think of vasomotor symptoms, but you can kind of assess, so menopausal related hot flashes. Other things you could think of would be maybe medical conditions such as maybe like a thyroid disorder, maybe something related to iatrogenic, related to like a medication side effect. I think it's helpful to maybe better classify or clarify, alleviating and exacerbating factors to assess. But the biggest thing I think of are hot flashes, maybe medication, thyroid disorder.
Okay, good. So you did think about something other than hot flashes or vasomotor symptoms related to decrease in estrogen. So let me say this: as OBGYNs, I think we're usually in that space of and I've said this every year, if it quacks like a duck, walks like a duck, waddles like a duck, we just say it's a duck. And when you're studying and practicing for your oral boards, you have to remember when you did that internal medicine rotation. I don't know if you remember, everybody would go do their rounds and sit in the room and then come up with this differential diagnosis that covered the entire wall, all four walls. And in your head, you're probably thinking, that person does not have any of these things. We have that one diagnosis. So that's kind of how you have to think, not just the patient's postmenopausal and it's probably the vasomotor symptoms that she has is related to the hormone change. So thank you. You did really good with that. So this patient's 53-year-old G1P1. Let's say she's not 53. Let's say she's 38. And she comes into your office because someone mentioned something about perimenopause. How would you counsel the patient if they said, what does it mean by being perimenopausal?
So I would tell the patient that menopause we define based on a cessation of menses for a year, and the perimenopause is the time around that, so prior to meeting that criteria, but it's but that's really just the way that we define it.
Okay, so the definition is, you're saying the definition of this, they have cessation of any type of menses for 12 straight months, right?
Yes, for menopause, and then perimenopause being the typically like 5 years leading up to that time.
Are you there?
Yes, did you hear me?
Oh, yeah. Oh, I didn't know you were done. So 5, yeah. So it can be, 4 to 8 years or so before that time. So what would a patient expect, I guess, during the perimenopausal period? If that's your patient is just like, how would I know if I'm in the perimenopausal period?
Yeah, and that would be, I would counsel the patient that can be difficult. So some people don't have symptoms.
Yeah.
Otherwise, sometimes people can have hot flashes. Sometimes people can also experience some mood lability. And then also leading up to that, sometimes prior to experiencing no bleeding for 12 months, they can have irregular bleeding up to that time.
Very good. Very good. So you're talking more than just vasomotor symptoms. You're talking about some other issues that the person has, including the abnormal uterine bleeding, increase in frequency, decrease in frequency, mood changes. Sometimes they have difficulty with insomnia. And it depends. You're right. It's very unique if the person's going to have any changes in the genital urinary system. So very good with that. So let me ask you, for this particular patient, 53-year-old G1P1, vasomotor symptoms, you counseled them regarding the vasomotor symptoms medical management. Just in general, what are the treatment options for a person who has hot flashes due to menopause?
The categories are non-hormonal options as well as hormonal medication options.
Good.
And okay, and then in terms of hormonal options, it's typically just combinations of estrogen as well as progesterone, depending on the patient, and different formulations, so pills as well as transdermal options, as well as potentially an IUD to administer progesterone if needed. In terms of non-hormonal options, there are the one that's FDA approved is an SNRI, paroxetine, Paxil, and then there's also gabapentin, which can be utilized for hot flashes as well. It's not FDA approved, but has been demonstrated to be efficacious for that purpose. And then beyond vasomotor symptoms, sometimes these patients are experiencing symptomatic atrophic vaginitis. And so then there are some local estrogen options that can be utilized as well.
Okay, good. So if you have a patient who says, I don't want to take any medicine at all, hormone or non-hormonal, what can I do to help my hot flashes?
So I would counsel them on some, I guess, lifestyle measures. So some of that is wearing layered clothing so they can kind of remove those layers depending on how they're feeling. And then also having the AC on at home is needed. Also avoiding certain medications or certain kind of food items such as caffeine, alcohol, kind of limiting those intakes, some chocolate as well, increasing their dietary fiber. Other things that have been evaluated include like exercise, which that might be helpful for mood and maybe kind of depending hot flashes as well, based on, I guess, the patient. Other things, there are some over-the-counter kind of supplements as well that can be utilized, but those are, there's things such as like ginkgo biloba and
Mm-hmm.
black cohosh,
Mm-hmm.
things like that have been studied. And the issue is they're not regulated by the FDA. And so typically I would caution the patient to, or I would, caution the patient to kind of utilize caution when kind of going down that route with the herbal kind of remedies, just because they're
Mm-hmm.
not as regulated. And so they may have side effects, and there might be some variation in terms of like the quantity, and then they may have quantity of the active ingredients, and then they may have some side effects as well, or sometimes they can also have impact on their like bleeding disorder, things like that. So we don't have as much information about those. I usually caution them to stay away from them if they can.
Okay. All right. Okay. So, wow, how do you take care of a lot of patients that are perimenopausal, menopausal, postmenopausal?
I do, but I think for this indication, like as a chief complaint, not as much.
Okay. All right. So I think that you have a lot of information regarding all of those states, perimenopausal and postmenopausal, which is good. I think the more you practice, you'll be able to organize it even more in a way that it's clear to your examiner. I would say that I would probably avoid saying that you caution patients from doing something, right? Only because you just want to still let the examiner know that you allow for autonomy. So, saying more of, I would let them know that there are some options that are non-medical options, supplements, um, give them the information about there's limited data, there's limited studies. It's not necessarily FDA approved. Anecdotally, it has been shown to help others. But just remember that anytime you take a herbal supplement, it can affect your body in a way that medication can. So allowing them to recognize, hey, this is not just like taking a vitamin or, popping an apple or something. It could have some effects. But not saying, I would tell you not to stay away from it. I would tell you, tell my patients to steer away from it. That's the only language that I probably wouldn't use at the time of the test. Does that make sense?
Okay. Yeah, that makes sense. Thank you.
Yeah. All right. So I am going to stop the webinar because I think we've gone beyond our time. I can't find my control panel. It's somewhere in here somewhere, but here it is. And I don't see that we have anyone else that has their hands up. I really appreciate so much the patience that you had as I was trying to get on tonight. And again, for those, if you have not had the opportunity to send in your case list, make sure you do that. And as much as possible, take advantage of getting in the hot seat. And we'll talk you through any difficult cases or just give you an opportunity to talk out loud. But even so, if you're not able to attend every night or participate every night, try to give yourself at least 15 minutes just to talk out loud one of your cases. You want to get into the habit of doing that. Best way to study for an oral exam is to talk out loud, okay? I wish you all the very best, and have a good night. This webinar is over.